Diagnostic imaging in spinal pain. General principles: no test shows pain. Currently, there are no clinically useful biomarkers for pain, nor can imaging or any other technique localize or characterize pain. Furthermore, chronic pain is usually a multifactorial problem. For example, in a patient with chronic low back pain, contributing factors may include degenerative joint disease, root entrapment, myofascial pain, muscle deconditioning, central sensitization, and the effects of mood and psychosocial circumstances. Clinicians must recognize when the cost of further investigation exceeds diminishing returns. Imaging studies. Many imaging techniques have been applied to the spine and its contents, starting with plain films, myelography, radionuclide scanning, CT, and MR imaging, were developed specifically to evaluate spinal disorders. Plain radiography. Plain films record differential attenuation of the X-ray beam by tissues based on their differential densities. Plain films are quick, inexpensive, and easy to perform and have excellent spatial resolution. Important information about the spine can be obtained with conventional radiographs, including alignment, structure, and mineralization. Dynamic weight-bearing upright flexion and extension views can reveal a stable or unstable spine in chronic and acute scenarios. This is the only modality to date that routinely achieves this type of stress-related imaging. Osseous foraminal stenosis and spondylolysis can be diagnosed with oblique projections. Vertebral fractures and joint dislocations can be detected. Slide. The cervical spine study include AP, lateral, flexion, extension, both oblique and open mouth views. Of the spinal canal by the introduction of a non-ionic, water-soluble, radiographically dense iodinated contrast material into the spinal subarachnoid space. This contrast material outlines the spinal cord and nerve roots, which appear as filling defects in the radio-dense contrast column. Non-conventional radiographs. Extradural indentations into the contrast column are observed. Spinal stenosis can be diagnosed and nerve root impingement can be detected. Redundant thickened nerve roots and arachnoiditis can also be demonstrated. Myelography should always be followed by a post-myelography computer tomography scan to provide better definition of anatomic relationships of the contents of the spinal canal to the surrounding structures. The use of myelography has decreased significantly due to the invasive nature of the procedure and the availability of other non-invasive imaging tools, including computer tomography and MRI, which provide excellent spatial and contrast resolution. Myelography is now used mainly as a problem-solving tool when computer tomography or MRI examination cannot be performed due to contraindications, are equivocal, or are limited due to artifacts from surgical hardware. Case 1. Plain film. The AP and lateral plane films of the ELS spine are unremarkable. After intrathecal contrast administration there is filling defect at root L5S1 and pressure effect on the root S1 root. The computer tomography showed root theramedian posterior disc extrusion and traversing S1 root compression and lateral recess are observed. Multi-detector systems, high-speed rotation, and dynamic table translation to optimally image the spine. Post-processing multiplanar reformatting, and three-dimensional data sets can be acquired. Differences in radiographic density of ligament, disc material, and cerebrospinal fluid make identification of disc herniations and ligamentous disorders possible using computer tomography. Artifacts from metallic surgical implants, such as spinal rods, transpedicular screws, laminar wires/hooks, and intervertebral/vertebral body cages can severely limit the diagnostic value of computer tomography images. In these cases, conventional radiographs and myelography may prove to be the best diagnostic imaging modalities. The radiation dose from computer tomography can be several times that of plain radiography. Therefore, children, pregnant females, and other young adults should be concerned. Helical computer tomography can assist spine surgery. Also, magnetic resonance imaging, MRI uses radiant fields and radio frequency waves to localize and characterize tissues based on hydrogen atoms, protons. MRI evaluates soft tissues such as discs, tendons, ligaments, cartilage and nerve roots. MRI allows precise definition of extradural, intradural, extramedullary, and intramedullary pathology. A non-contrast MRI is sufficient in the majority of cases. MRI scans can show change in marrow signal and can demonstrate abnormality in tumor, inflammation, or reactive bone sclerosis. Radiant echo pulse sequences have produced high signal from CSF with relatively short acquisition times, resulting in myelogram-like images. The addition of intravenous gadolinium allows better imaging of infection, tumor or fibrosis. Advanced DWI of the cord was success and have a great value in differential diagnosis. MRI spectroscopy study reveal metabolism in cases of cord ischemia. Strict contraindications: cardiac pacemakers, metallic foreign bodies. Specific metallic surgical implants cannot be evaluated. Programmable VP shunt may be disabled or reprogrammed. Case 2. The cervical MRI showed posterior herniate disc from C3/4 to C5/6 level. Case 3.